Is it okay? Everyone can see?
Yes, Cerebral, we can see.
You can see, huh? Okay. Let's start with the first question. So, this is a term neonate who did not pass stool till 48 hours of life. Baby was noted to have abdominal distension and pass meconium after rectal stimulation and washout. So the question is, what are the differential diagnoses? You can put your answers in chat box, then I will go to the next question on this. No answers yet. Has anybody replied? I can't see. Okay, meconium plug. Yeah. So this is a delayed passage of meconium. So what are the possibilities? It could be a meconium plug. Yeah, there is a somebody has written ileus. Okay. Okay, so let's go ahead. So there is a history of previous sibling who died at 6 months of age following recurrent respiratory infection. So what underlying condition should be suspected in this? Now you got more history. This is a delayed passage of meconium. There was a previous sibling who died. So what should be the possibility here? Cystic fibrosis, yeah. Somebody has answered. Anybody else? Okay. Any more? Everyone has written few cystic fibrosis, yeah. Somehow I'm not able to move the slide. So what is the screening test and confirmatory test for the suspected condition? So for cystic fibrosis, what is the screening test and confirmatory test? So yeah, meconium plug. Even if you don't know the history, Hirschsprung disease can present with the delayed passage of meconium ileus. The question B is cystic fibrosis, and the right answer is immunoreactive trypsinogen. That is the screening test. And for confirmation, you would like to do genetic test for cystic fibrosis. So the next question is, what is the abnormality shown here in the picture? What is this test known as? What are the risk factors for the underlying conditions? And what are the other tests can be done clinically to evaluate the condition? Yeah. Somebody has written Galeazzi test for DDH. Anyone else? What are the risk factor? Anybody want to mention B and C as well? Okay, C, somebody has written Barlow and Ortolani. What is the answer to B? So correct. Galeazzi test, basically with the knee flexion and feet on the floor, you would like to compare that. You can see the difference in the level of the knee joint between both the feet. So while the infant's feet are on flat on a surface, the knee of the affected side appears lower. The risk factor is the extended breech positioning, particularly in the late gestation. That is the risk factor for developing DDH. Female infants have a 4 to 8 fold higher risk than males and maternal hip dysplasia because of the genetic factors increases the offspring risk. What are the other two tests you would like to do? There is ortolani and Barlow's. Apart from that, you might be able to see some asymmetry of thigh and posterior gluteal folds. And there is a limited abduction of the affected hip. So one of them is a Barlow and ortolani in this picture. We go to next question, number 3. A term baby who is known to have a bilateral antenatal hydronephrosis underwent postnatal investigation. Please mention what is the investigation which is shown here and what is the name of the radiological sign which has been shown. Then name the subsequent investigation and what age it should be done. And C is what precaution should be taken while waiting for the further investigation. I've not got any answer yet. What investigation is this? You can write in the chat box.
Chat box is apparently disabled. Only people who are in this can access the chat box. Participant.
Yeah, but still some people are able to write it. Last time a lot of people wrote it down, sir.
No, they can answer in Q&A, but not in chat box.
Yeah, Q&A. I'm just seeing that only. Yeah, Q&A. But nobody has answered for this one yet. So yeah, someone did that. So keyhole sign, yeah, USG KUB, correct. So this is a USG abdomen or KUB, and this sign is known as a keyhole sign. What does it mean by that? Appearance of the proximal urethra, which is dilated, and an associated thick wall distended bladder. The answer to question B, the subsequent investigation is MCUG. And what is the age it should be done? Preferably when you suspect that there is a lower urinary tract obstruction, the ideal age of doing a MCUG is around 48 hours of age. And the answer to C is what precaution should be taken while waiting for the further investigation is that baby should be commenced on antibiotic prophylaxis. Okay, so the next question. So yeah, this is the flow chart and just highlighting whenever there is a features of lower urinary tract obstruction, you should perform MCUG within 48 hours. And if it is a luto present, then you refer to pediatric surgeon suspecting posterior urethral wall. Okay, so what is the cause of the highlighted pattern in the following 3 pulmonary graphs? Okay, so you answer as A, B, and C. Can you quickly answer in Q&A? What does that pattern indicate? I have highlighted with the circles. B, auto peep, okay. What is A? A is a beaking in over distension, A high PIP, auto peep, air trapping, beaking. And anybody for C? Okay, let's go to the answers. So for A, It is. So for A, it is beaking or overinflation. So you can see that you are increasing PIP, but the volume doesn't increase. This is the pressure volume curve loop. If you increase pressure and the volume doesn't increase, there will be a beaking. So that is a sign of overinflation. So you can't increase pressure on that. Number two is a flow volume loop, and this is the sign of air trapping or auto peep. So you can see that this does not go to the zero, and there is even before the next before this breathing completes, the next breathing will start. And in C, it is leak. Yeah. So this is a pressure volume loop, and this area indicates there is a leak. So it doesn't touch the baseline. So I have shown this. Sorry, this one. Expiratory flow does not return to zero. Baby is still exhaling when new breathing begins. And the commonest causing of air trapping is extrinsic factors like increased expiratory resistance in the circuit with small ET tube or excessive secretions, insufficiently set E time. When your E time is less, then there will be air trapping, and partially block ET tube. Expiratory limb suddenly disappears or looks like suddenly dropping. That is a leak. ET leak due to small size could be the cause. If there is a detached or loose ventilated tubes or loose water trap can cause this kind of air leaks. The next question is, baby was born at term with a birth weight of 3.2 kilos, present on day one with excessive oral secretions and poor oral feeding and cyanosis. So name the specific anomaly from the X-ray. From this anomaly, which subtype of this anomaly it is, and what are the antenatal scan findings which can raise the suspicion of this? So you can see that there is a coiling of feeding tube in the upper esophageal pouch. But there is a very prominent second anomaly is that there is absent stomach gas. Okay. So this is definitely esophageal atresia, and there is obviously no fistula between the respiratory tract and GI tract because there is no gas bubble. So which type of atresia would it be? So basically this is a esophageal atresia, TEF, which one be classified as a type A and B, and the antenatal scans will be suggestive of polyhydramnios and absent stomach bubble. So if you look at this picture, type A and B, where there is a respiratory tract and alimentary canal, there is no direct connection between the lower esophageal pouch and respiratory. So in these two cases, there will be no gaseous shadow. So we have to highlight these two are the causes of this X-ray. Though the most commonest type is type C, as we all know that. Okay, this is an interesting one. I have shown a graph here. There are three fetal curves. Okay, the curve one is a green one, curve two is a blue one with the dotted lines, and curve three. These are the growth of three different babies. So the question is, of the following graph that represents fetus with the IUGR is, you have to choose from one option. So in number one question, which curve suggests there is IUGR? Whether it is curve 1, curve 2, curve 3, or whether curve 1 and curve 2. Okay. And the second question is, of the following, the most likely cause is fetal growth pattern in curve 3, whether it is a familial straw stature, maternal gestational diabetes, pregnancy-induced hypertension, or twin gestation. Okay. So what is apparent in these two graphs is that curve 3 is below 10 centile from beginning till end. Okay. So it meets our definition of SGA babies because SGA is always below 10 centile. If you look at the pattern of curve 1 and 2, the curve 1 was to begin with 75th centile and it drops at certain point below 50th centile. And same way, curve 2 begins from 25th centile and it drops to below 10 centile at certain point. So IUGR and SGA, though they can be used interchangeably, there is a slight difference in their definition. So I will just define a fetus or infant who has a growth restriction if the intrauterine rate of growth is less than the predetermined growth potential of the fetus. So if we go back to the slide, the growth potential of curve 1 was to stay on 75th centile and it has dropped. So it is the concept related to your growth potential. So curve 1 and curve 2, these two both are an example of IUGR where the growth was potential has been higher, but it has shifted in certain point at certain point in the pregnancy due to some insult. Now, if you look at 3, that is a graph of an SGA baby. So what is the definition of SGA? A neonate is described as being SGA baby's birth weight is lower than that of the standard population, typically lower than 10 centile. So in the concept of SGA, it remains throughout below the 10 centile. However, this is the baby's maximum potential. So if you look at the 4 options, the option A is the right answer, familial short stature, because your growth potential is lower. So that baby is always going to stay smaller. If you see maternal PIH or gestational diabetes, they are an insult at certain point in gestation, which will lead to growth restriction. Same with the twin gestation. So the right answer would be familial short stature. Okay, so the next question is, so this is a slide of investigation amplitude EEG or cerebral function monitoring. Okay, I have given 4 different patterns and you have to identify what pattern it is. So A, B, C, D. You can write down in question and answer. So number A is a normal trace. You can see in CFM, those who know, they will know, but those who don't know, you have to see the width of this band and the lower margin and upper margin. Okay, the lower margin should be, this is a 5 microvolt and this is a 10 microvolt. So when your lower margin is above 5 and upper margin is above 10, with a sleep wave cycle, it is a normal trace. Okay. This is a moderate encephalopathy. Particularly, the definition of moderate is when your lower margin is below 5, you can see that the width of the band is very broad and the upper margin is above 10. That is known as a moderate encephalopathy. Third pattern is known as a burst suppression, which is also a form of a kind of moderate to severe encephalopathy, where your lower margin is below 5, but you are getting a lot of burst, burst in this suppressed pattern. So it's like a kind of a comb appearance where a lot of bursts are there on the background of a very suppressed margin. This is a burst suppression pattern. And last one, which I've showed here, now you can see that there are multiple spikes of very high voltage. You can see that these bright blue color spikes, which are happening very frequently. If you can see in this just a pattern, there are more than 10 spikes are there. So this is a multiple seizures. So whenever you will get a seizure on amplitude EEG, the electrical activity will shoot up and it will be appearing in a form of a spikes. So this is the classical of multiple seizures. Even though it is not apparent clinically, these are definitely electrical seizures and you will have to treat. This is more or less status epilepticus kind of pattern. So to go through just for reference, I'm putting it here. This is the classification. There are two classification of amplitude EEG. There is a voltage and pattern classification. So voltage one is a simple where it is a normal, moderate, and severe, which I already explained. In pattern, there is a different patterns like flat trace, lower voltage, burst suppression, which also we discussed. The other normal pattern is a continuous normal voltage. So whenever you have got a baby with a perinatal asphyxia, you can use this bedside investigation. Apart from that, you can use it to diagnose and treat electrical seizures. It can also be used in metabolic encephalopathy. Question 8. So a 690-gram female infant is born at 24 weeks. On day 2, baby is on starter parenteral fluid, which consists of dextrose, sodium, and protein. At 36 hours, baby's investigations are suggestive. Sodium is 143, potassium is 7.5, chloride is 110, and bicarbonate is 18. What is the most likely etiology of hyperkalemia in this baby? What are the ECG changes would you expect in hyperkalemia? And what are the drugs to be used in hyperkalemia? You can answer in question and answer. Okay. Okay. So the answer is that hypokalemia results from a potassium shift from ICF to ECF space and this is very common in VLBW in first 72 hours. So that is why your potassium is bound to get little higher in the first 72 hours of life in these small babies because there is a shift of the potassium. So that is why we restrict to add potassium into IV fluid. Hence, it is not there in the starter TPN. And it is recommended that this potassium is to be added only after the baby passes the urine. So that is the reason why you get a physiologically sometimes high potassium in extremely low birth weight infants. Now the changes of ECG would be according to the levels. I have just kept this for the reference. The commonest we see is a peak tall T wave, like you have seen in this photo picture. Peak T waves is very well seen in the ECG when there is a level between 6.5 to 7. However, when it is a very high, you will get more changes in form of flattened P waves, which is shown here, and then it can lead to the prolonged QRS complex. And at last, when it is a lethally high 8 to 10 potassium, you will get a typical what we know as a sine wave, where there is a merging of this S and T. And this is known as a sine wave. It is like a mathematical sine wave. Yeah. So these are the typical changes of hyperkalemia. Treatment we all know very well, but still just to briefly mention calcium gluconate, which is a membrane stabilizer. Insulin and salbutamol are the drugs which will shift it to intracellular compartment. And furosemide, bicarbonate, and potassium exchange resins are there, which will excrete them in the urine. So most important thing we need to know is about calcium, which will stabilize and it can be helpful. Salbutamol is unfortunately not available IV in our practice, but it has been very useful in management of hypokalemia. So the next question is, what is the diagnosis in this picture in a 1-day-old neonate? What is the common cause of this condition at this age? And what are the syndromic associations? So it is very easy and apparent on the picture. I expect a good number of answers. Okay, so right, it is a left-sided facial palsy. We can see that there is a obliteration of nasolabial fold. There is a deviation of mouth. and the left side of eye is open. So this is a classical left-sided facial nerve palsy, which is been noted after on day one itself. So the commonest cause is a perinatal trauma. Sometimes instrumental injury or any pressure or any compression can lead to lower motor neuron facial nerve palsy. The other cause is a congenital abnormality, and the other associations are Mobius syndrome, which is a genetical cause for absent facial nerve palsy. There are some other associations, which is the Charge syndrome, which can be present with facial nerve palsy, and golden hour syndrome, which can also be a part of facial nerve palsy, can be a part of it. So the last question is a 1-month-old baby who presented to you with seizures, pallor, and altered sensorium. Baby was born at term at home by normal vaginal delivery. Baby was exclusively breastfed and was thriving well. You do a head scan, which is a cranial ultrasound scan, which I have shown the picture. Can you tell me what is the diagnosis from the picture and what is the most likely underlying pathology, etiology? How can you prevent this happening? And what are the other ways of presentation of this condition? Okay, so good number of answers. So it is very obvious on the cranial scan, there is a large intraventricular and intraparenchymal hemorrhage on one side. Okay, so this baby presented at 1 month. This baby was home born, and this baby was exclusively breastfed. So the most likely underlying cause is a vitamin K deficiency, which presented as a late hemorrhagic disease of newborn. How could you prevent it? So you can prevent it by giving intramuscular injection of vitamin K at birth, 1 milligram, and that will help to prevent the late hemorrhagic disease of newborn. The other ways of presentation of this condition, when this presents early, within first 24 hours, this is known as the early hemorrhagic disease of newborn. When it presents as a majority of the cases, the early presents with the intramuscular hematoma at the site of injection. Classical HDN usually presents between 2 to 7 days, which usually presents with a GI bleeding, either hematemesis or bleeding per rectum or blood from the umbilical stump. And this is the late, which usually presents with the 2 weeks of age to, it can present up to 6 months of age actually. And the most common age of presentation is between 2 weeks to 2 months of age. And it usually presents with intraventricular or intraparenchymal bleeding. And actually late hemorrhagic disease prognosis is not good depending upon the extent of the hemorrhage, but it can lead to death as well. So I think that's it from my side. Thank you very much. That is all we are done for tonight. Dipen bhai, over to you.
Yes, Jatin bhai, thank you very much. It was very interacting OSCE MCQ session, and it was also great to know some newer things. So I thank Dr. Somsekhar sir and Dr. Jatin Mistry, and I congratulate all the three presenters for presenting their session. I am officially closing this session. Thank you.
Thank you, Dipen bhai. Thank you.
Thank you, sir. Thank you, sir.
Thank you, everybody.
Sir.
Good night.
Wait. 10:45.
Yes.
That's the interesting part for everyone.
Sorry, sir.
The interesting part for everyone. Myself and Jatin both were watching the match when Dipen called us to say that, can you do this session?
Yes.
We were in a stadium.
Both of us were in the same stadium.
Yes.
and I told him I will reply tomorrow.
Yes.
Anyway, good to see everyone. Bye. Good night.
Good
Thank you,
night,
sir.
sir. Good night.
Thank you.
Right, sir.
Thank you.